Welcome to Swallow the Gap, the podcast that delves into the critical world of dysphagia practice and education. I'm your host, Dr. Tim Stockdale, and I'm thrilled to have you join us for conversations aiming to bridge gaps in understanding, knowledge, and implementation surrounding dysphagia intervention. We will be a force for change by inspiring critical thinking, facilitating discussion, and promoting professional development. Swallow the Gap is here to discuss, inform, inspire, and connect you with a vibrant community who is dedicated to making positive change. Together, we'll unpack challenges and be open about our own struggles and work to bridge gaps in our field that impact the lives of those living with swallowing difficulties. Our opinions should not be taken to represent our employers or the groups with whom we associate. Nothing we say is legal advice, and nothing should be taken without scrutiny. While we strive for accuracy, we do not imply perfection. We value diversity in backgrounds and opinions, so our guests will not always reflect what we believe. In fact, we may change our minds on topics as we learn because this is how progress is made. Through discussion, critical thinking, and open minds, we serve as catalysts for advancement in medically focused speech-language pathology. Today, we'll be talking about what some have called a dual diagnosis with Rinki Varindani Desai, who has been with us recently, so I won't go into a deep intro, but she's a medical speech pathologist, board certified in swallowing disorders, and is the co-founder of the Swallowing Training and Education Portal. We also have Dr. Jeannette Benigas, who's a speech pathologist, professor, owner of a mobile fees business, and probably lately you know her best as the co-founder of Fix SLP. And also, I'll put something in the description of the episode, but you have a recent MedBridge course series coming out. So hopefully point people that direction as well.
Yeah, I have two. The Diet Waiver Alternative, How to Advocate for Patients' Rights, which is what we talked about on the last episode. Mm-hmm. And then the other one is a little more related to what we're talking about today, but it's called The Other Dysphagia, Pre-Oral Dysphagia Evaluation and Treatment. Oh, I was looking up let me say it again. The other one is more related to what we're talking about today. It's the other dysphagia, okay. Pre-oral dysphagia evaluation and treatment.
Good deal. Good deal. Well, I gave you all very short notice to come onto this episode, so I appreciate it. But y'all are pretty laid back. I know you're both very knowledgeable about this topic, so I'm not worried. I think you are equipped. You could probably present a 3-hour course on this if we had 3 hours. But what I wanted to start with is we've all heard about the papers from 2018 about SLP competence working in general with patients with dysphagia and specificity in treatment, practice patterns, that type of thing. But what I recently, and to my shame, learned about was, Rinki, this article that you collaborated on and published about the same sort of thing, but specifically in patients with dementia. Would you mind telling us a little bit about that?
Yeah, I partnered with researcher Dr. Ashwini Namasavaya McDonald, and we looked at practice patterns of SLPs managing dysphagia, specifically in individuals with dementia in the US. And I think for those who aren't aware, there's paper after paper that has been published since 2005 that shows that SLPs are not graduating feeling prepared, feeling confident or competent in managing dysphagia in adults. We have the same kind of findings in individuals working with more specific populations like head and neck cancer, school-based settings. And we wanted to see, well, how are clinicians feeling about managing dysphagia in dementia specifically? And not to our surprise, and as we had hypothesized, a majority of our respondents said they weren't trained to work with the complexities and the challenges of this population. A lot of the assessments they're using are not validated for this population. A lot of the treatments were mainly conservative, like modifying diets or maybe caregiver training, maybe doing some kind of environmental modification, active rehab with this population. And there was an overwhelming feeling of either we don't know what we're doing, or is it going to matter anyway because this is a progressive disease and they're just going to get worse. So I think there's so much more that needs to be done in terms of just clinician training and education. And we asked about specific barriers that are limiting them from doing better with these patients. And I think a lot of the barriers too were like not having enough support, not having enough awareness, not having enough resources and training to even advance their learning to specialize in working with this population. So there's just a lot of problems to fix. And I think it mirrors what we're seeing about the general state of dysphagia training and education across the board.
Yeah, that's really what I took away from it, is it really kind of mirrored that too, what I've read about in other publications. So you mentioned the idea of progressive disease and how it gets worse. And I feel like that is something kind of across the board that we struggle with altogether. So you had also mentioned the idea of exercise. So exercise, not just compensation, caregiver training, and environmental modification, but exercise. How do you think we can better incorporate that into working with patients with dementia who also have dysphagia?
Yeah, and I'd love for Jeannette to jump in as well. But like you said, it's the dual diagnosis challenge, right? So you're not just dealing with somebody with a swallowing impairment, there's an underlying reason for it. And not similar to patients with a very specific diagnosis like stroke or something else. Dementia is a cluster of symptoms. It's not just one disorder. You could have Alzheimer's, FTD, Lewy body. You could have different types of dementia that result in different types of swallowing impairments at different stages of the disease. There's a paper by Dr. Alaga Krishnan and all, where she's done a systematic review of all the different types of dementia and what the dysphagia presentations are like, which was really eye-opening for me as well, because I don't think we tend to think of our patients as being separate when they have a dementia diagnosis. So what's important is you assess their swallowing as you would with any other patient. You want to do your clinical assessment, try to get imaging when it's warranted, which is most often than not. And then you identify the underlying swallowing impairment at the motor level. But what's another layer that's really important here is a lot of our patients with dementia have sensory issues that we need to take into account as well. And then they have those cognitive and behavioral issues that we need to account for. And then on top of that, you have what kind of caregiver support and assistance they have, because a lot of our recommendations will depend on what kind of support these patients can get to actually follow through with those recommendations and treatment modifications that they need. So we do have to take on an active role with a lot of these patients. You don't have to assume they're just not good candidates for therapy just because they have a dementia diagnosis. And you really have to think of it as not being a one-size-fits-all approach.
Sure.
And then as the disease progresses, you may have to switch on that active hat to a more passive hat and think about how you're educating people working with this patient, how you're advocating for the patient's needs, and really, really pushing to be an ally to support this patient's maximize this patient's quality of life. So there's a lot we can do from the day they're diagnosed to the day towards the end of life. You just have to keep switching your treatment plan and your role with these patients. And Jeannette, I'd love to hear your thoughts.
Yeah, I'll jump in there too. I have a couple points I want to talk about. In terms of exercise, if we think about the exercise science research, we see that people can gain muscle mass all the way up until they die. So just because someone has dementia doesn't mean that they can't improve their muscular function, their motor function, right? So we don't see PTs not treating people with dementia because they have dementia. They are still enrolled in therapy all the time for walking and sit to stand and stand to sit. So I think we need to think more like our colleagues in that sense. But what's even more important is if we're going to do something like that, we have to know the pathophysiology. And something I see a lot is, well, we only do instrumentals if it's going to change the course of treatment. And so there's no reason to do an instrumental for someone with dementia because it's not going to change the course of treatment. But it actually could, because families need to be able to make decisions, and the only way they can make decisions is with information. So if they don't know about the pathophysiology, if they don't know what their options are, they can't make an informed choice, and that's very important. So it also shouldn't be ruled out. They might do fine with the fees. They could do a modified barium swallow study. You'd be surprised how many people I scope with dementia who sit there and act like nothing is happening. And that circles into that sensory issue that you talked about, Rinki, too, is that their peripheral nervous system is shot. It's why we see pocketing. It's not triggering their central nervous system to create a motor output to chew and swallow. So sometimes it's easier to do the fees because you don't have to take them out of their environment, or sometimes they'll beat you up. It just depends on the person. But I wouldn't rule out one or the other. If you only have access to one thing, then try it. But it is really important to secure that instrumental exam if you can, so you can make a good person-centered plan.
A lot of patients also end up, the older we get, we have evidence to show that with the aging swallow, you already have individuals with presbyophagia who don't need to have a dementia diagnosis, but they have oral and pharyngeal function that's changing, that's predisposing them to dysphagia. And then now you have increasing evidence to show that there's a high prevalence of esophageal disorders in this population as well. I've had patients who literally couldn't swallow because they had something like a Zenker's diverticulum. Maybe they had UES issues that there's no way you can always pick up on that on something like a FEES. Not, like you said, a FEES is a great exam to have if you don't have access to MBS, but I don't think you should think like, I shouldn't push for an MBS, I shouldn't push for imaging because it's too much to transport this patient from a nursing home to a hospital, because those are things that you can't fix. If someone has a Zenker's and that's why they have swallowing issues, I could do all the therapy in the world, they're not getting better. Or if they have, a CP bar or something else that needs medical intervention, how are they getting better? So you just can't assume you know what's going on at the pharyngeal level without getting those imaging assessments in. And once we have that information, we can then make a very individualized treatment plan to decide what's the next best step for this patient and how can we make them as safe and efficient as possible in their swallowing.
Jeannette, you said something that I thought was interesting. You said that people will say, well, we're not going to do this because it's not going to change the course of treatment. And I'm like, that sounds so circular. That sounds like you're assuming that you know what the outcome is going to be on the instrumental study. So like, oh, I'm not going to do it anyway because I know what's going to happen. But it really sounds like circular logic to me, that it's kind of predicated on itself. And it doesn't make a lot of sense. I mean, I can certainly sympathize with the scarcity of resources, the difficulty in getting a mobile fees company to come in if you're at a nursing home, or transporting them to the hospital or something like that, or having a fees provider come in. There are so many barriers, and I think, of course, we have to be mindful of that, but still, we've got a job to do. We've got something that we have to do, and we can't just predicate it all on guesswork. And that brings me back to this article that Ed Bice et al. In 2023 published, that among 120 SNF patients, and I don't want to make SNF synonymous with dementia, but there's a huge proportion of individuals in skilled nursing facilities who have dementia. But of this, among 120 skilled nursing facility patients receiving swallowing therapy, they then had a FEES. 61% of those with feeding tubes did not have dysphagia. It doesn't say they didn't have severe dysphagia. They didn't have dysphagia. And then 2 out of 3 patients receiving a modified diet didn't have dysphagia. And so the question that I want to put out there, and it's a little bit of a loaded question, but it's also, hopefully will get our attention. Are we doing more harm than good on average? As things are right now, do you think we're doing more good, or are we doing more harm? And this is a scary question for me. I mean, reimbursement, all these things, but you got to talk about it if we care about these individuals. Sorry, Jeannette, go ahead.
I'll take this because I've done 7 studies in the last 2.5 weeks. And at the last one I was at, I looked at the clinician and I told her this was my 7th in like 2.5 weeks. And I said, let's go 7 for 7. And what I meant was the previous 6 studies that I had done, those people were either NPO with a tube or on a severely modified diet, like honey and puree. One person was on a pudding thick liquid and puree. 6 out of 6 did not have dysphagia. Nothing wrong with them. No, I think one report might have had one instance of aspiration that was cleared, but it was insane to me. And some of them did have a dementia diagnosis. A few of them did. And something I always ask about is the bun level and dehydration and intake, because when we're making these decisions for people with dementia, they're already cognitively impaired. And now we're upping their risk for UTIs and upping dehydration, which is going to make them more confused. And it just all compounds. And by the way, we didn't go 7 for 7. That 7th person actually did have a dysphagia. But to me, that a lot of these people had been harmed and none of them really had extended hospital stays. couple of them had just been out for 1 or 2 or 3 days. It wasn't like this long extended thing where they had this swallow study early on when they were really acutely impaired. There was nothing super significant going on where their medical status changed a whole lot. So that's really concerning to me. And I bet my story is not unique.
I don't think it's unique either. One thing that I want to go back and caveat, because I think so many of the listeners are listening because they want to become better and they want to make things better. I mean, that's a huge reason why I'm doing this, is not just to help to try to get things going in the field to make things better, but I need to get better too. And so like talking to you and talking to Rinki and talking to all these other individuals, like I learn a lot from this and it helps to broaden my perspective. And so like, I hope that nobody listening has the perspective that we're sitting on a pedestal, like pointing our fingers down and like, shame on you, because that's not what this is. But it is still the idea of, we want to help our patients, right? I don't think no one's going to argue with that. We want to help our patients. So how do we have to look at the current state of things to see how we can make it better. Jeannette, there's one more thing that you said that I want to kind of bolster off of. I personally feel like there is this hyperfixation on swallowing safety to the exclusion of things like nutrition and hydration and quality of life. We're very focused on safety. And so with reason to a degree. So think of the idea when you hear about a plane crash on the news. You hear about a plane crash, everybody hears about a plane crash, right? How many people die of plane crashes a year? Not a whole lot. But if you hear about people in nursing homes dying of dehydration, getting a urinary tract infection and getting kidney failure and all these sorts of things, like you don't hear about that on the news, but that dwarfs completely the idea of plane crashes. And so going away from plane crashes, choking, people asphyxiating in nursing homes. When that happens, it is scary. It's vivid. But I guarantee you, that's a big word, but I am willing to bet a lot of money that so many more people die slowly related to things with malnourishment and dehydration than people who asphyxiate. But it's the lawsuits that come from asphyxiation that scare the crap out of people to think like, well, okay, putting thick liquids or honey thick liquids. But it's this idea of misleading vividness, that something leaves an impression in your mind. There's a fallacy called misleading vividness, that you see things like a plane crash and it leaves this impression in your mind. You're like, I don't want that to happen. I don't want to fly in a plane, even though it's safer than XYZ. And so you translate that to people asphyxiating or choking in nursing homes versus all those who are dying slowly because they're not getting the nutrition and they're not getting the hydration that we need.
Yeah. You made the point. Was there a question there?
Well, I think we just need to look at the data, right? So here's the data. The data tells us that SLPs, physicians have been surveyed, and they say that the decision to put a feeding tube in is very likely going to be dependent on what an SLP recommends. That's the level of power we have to determine if someone eats or not. The data also tells us that feeding tubes don't prolong survival, don't minimize risk of aspiration, and don't necessarily improve quality of life in individuals with dementia. And then we have data to show that the highest population after stroke that receives feeding tubes are individuals with dementia. So obviously there's a huge disconnect between just what's been published and studied. And then SLPs, anecdotally, I'm sure we've seen that too, like you said, Jeannette. But then again, we have data to show that SLPs, the treatment they're opting for most often with these patients is conservative. So it's modified diets and it's feeding tubes. And within modified diets, whether they're on nectar thick liquids or honey thick, we know now that that's not the only reason they're going to get aspiration pneumonia and die. In fact, it could very well lead to aspiration and then leads to higher incidence of pneumonia than aspirating on thin liquids. But there's also things like how mobile they are, what age they're at, what medication side effects they have, what kind of oral care they have that determines that person's overall status and safety that we're trying to protect so much. But like you said, if they're malnourished and dehydrated, which again, the data tells us they will be because modified diets are not appealing to these patients. It's not what's natural and organic for them. It doesn't connect with their earlier memories about food. We're taking away even the little that they could eat and the quality of life they could have just because it's either easier for me as the only SLP having to get my 200 minutes in a day because I'm in a productivity-driven culture, or it's easier for that one nurse who has to watch 12 people eat at lunchtime. It's way easier to know someone's not going to choke and you throw them, a honey thick liquid and a plate of puree, and you don't care if they eat or not. That's just the reality of a lot of nursing homes. And there's so many issues there that we need to just do better to advocate for our patients.
I want to unpack that for a second too, because when we say asphyxiation, we're talking about something blocking the airways. So like a piece of chicken or a hot dog, so I could see changing something from like regular to mechanical soft, right? But people, correct me if I'm wrong, because now I might sound dumb. People don't asphyxiate on a liquid. They drown, right?
Yeah.
Yes.
How many people have asphyxiated or drowned that we know of from liquid in a nursing home? We're not giving the Heimlich for liquids, right?
Yeah.
So why, if we're worried about someone choking, we would change the diet, not the liquid. That terminology drives me crazy too, when a nurse will tell me, oh, she choked. And I say, did she choke?
Did she turn blue?
Or was she coughing? Was something blocking her airway? Or was she coughing? And what was she coughing on? Was it a solid or was it a liquid? Differentiating that for me is always important too, because no one is asphyxiating on thin liquid. If they could drown, but their airway is not blocked.
I did an in-service recently, and that was like one of the main takeaways is this is what choking is. This is what choking is not. Choking is not coughing with thin liquid. Choking is when you can't breathe and you turn blue and you got to give somebody the Heimlich, or you cough and shoot up, whatever it is across the room. No, I'm with you.
Coughing is not dysphagia. That's important to mention too, because again, with older patients, you have COPD. In a lot of dementia patients, their cough could purely be behavioral or like a sensory thing they're doing. They just have other respiratory like complications because they've probably had a trach or something at the hospital. Like there's so much more that could cause a cough than just dysphagia. And I think, again, it's our job to educate nursing staff and anyone working with the patient that they don't have to be afraid of the patient coughing.
In a way to start supporting clinicians, when I write reports, if people are coughing and I'll put unprovoked by the presence of food or liquid. Just so if it's someone that I know is on this like nasty diet and we're going to like give them thin and regular or whatever, and the clinician is afraid, like he's coughing all the time, I am specifically putting that in the report. Now, every time someone coughs on every trial, if it was unprovoked by food or liquid, I put it just to help that clinician fight that fight. Because I know that it's going to be a fight, right? That they're going to go on the weekend and the nurse is going to downgrade them again. And
oh man,
so I've been documenting that recently just to help support.
Oh, and talking to
people. Happens all the time.
Yeah, and talking to people and documenting that you've talked to them, because we know that nurses are stretched very thin, and they don't read every note. I mean, I don't read every nurse's note, but anyway, just emphasizing communication. Rinki, you said something about let's look at the data. Let's look to see what the data say. And so like, I'm really fixated on this idea of plane crashes. So like, pretend that I come from outer space and I land on Earth and I can speak the language and I'm observing. I'm like, okay, these people, they live about 70, 80 years. These are the ways they die. And I just see on the news, plane crash. And I'm like, oh, that is scary. Like, people die in plane crashes. I just know a little bit. I don't know a lot about how people die, but it imprints itself. It gives an impression to me. Or like shark attacks or whatever it is. Those are big deals. And so maybe I have good motives and I want to go out and I want to fight these sharks, or I want to save people from these sharks, right? Or save people from these plane crashes. But the more and more I learn about the data, about what actually kills people, I'm like, okay, let's cure cancer instead. Let's work on smoking cessation. And so I feel like the analogy then with SLPs coming out of grad school, one dysphagia course that maybe, okay. And so we don't know a lot. And so we're like this alien transplanted into a medical world that we're like, someone's going to choke. I saw somebody choke, or I heard about somebody choking, or heard about aspiration pneumonia. So we know a little versus, and I don't want to de-emphasize how many people do die of prandial aspiration pneumonia or people who do asphyxiate, but proportionally, as we learn more about the data about malnutrition and dehydration, I think it helps us to calibrate with a broader focus. The more that we know and the more that we dig into the data. again, I don't know where the question is in that. And I might have just said the same thing that I said a few minutes ago. That's just
That's
how
okay. We can kind of discuss like what happens. So you are having worked in a nursing home for 4 years. We've talked about this the conversations we've had, but I think there's a misconception that acute care is like this complex, challenging environment, and it's like the most sought after job, and it's a really difficult setting to be in. I look back and feel like my 4 years in acute care were a dream, because if you screw up and do something wrong, there's 10 other people to take over. Everyone's hyper focused on these patients. You want to get them out of the hospital and get them to the next
safeguards.
level of care. And the families are more invested as well because something new and acute has happened, right? Versus transport yourself to being a clinician in a nursing home, where most of our new graduates end up because SNFs are the only ones offering them medical SLP jobs. You're likely on your own. You're with patients who've had this diagnosis for a really long time because it's a chronic problem. So the families are either depressed, emotionally distressed, not invested enough, so they don't have caregiver support. You likely only have nurses who are overworked, underpaid, so you don't have the whole like medical team helping you. It's a really, really difficult environment to be in. So I really feel for those clinicians because I've been one, and you don't always have access to instrumentals. But there are still things we can be doing to prevent that malnutrition, dehydration. And that would be really honoring that person's dignity, their life story, understanding their relationship with food. They might need 6 frequent like snacks a day versus like the 3 big meals they're put on a table and expected to eat. You have to modify their environment. You might have to offer finger foods or be culturally sensitive about what foods might make most sense to that person. And again, educate and train, whether it's exercises they need to follow and they need reminders to follow that. They need a visual to remind them to drink. You can do space retrieval training. Like there's a lot you can do that is evidence-based to make sure they're eating as much as they can and you're preventing that malnutrition and dehydration as much as possible.
I'm glad you brought up space retrieval training because that happens to be what I did my PhD on. Very specifically was
really
teaching. Now this is very old school. You're going to have to dig deep into the literature to go find it. But training people with dementia to use swallow strategies using space retrieval. And it was a single subject design. I think it started with 6 subjects and someone had to drop out, but it was 100% successful. 100%. Everybody was able to use their strategy. And now, follow up, was I following them for years? No, but you do have to do quarterly assessments in nursing homes. So when I teach about space retrieval, that's something I always say, that if it's something that remains relevant, if you taught something in your therapy that remains relevant, pick them up for that quarterly and give them a booster session to make sure they're still doing it. And my research was the very first study that ever incorporated a continuous visual cue when people were eating and drinking, and especially using spaced retrieval. And so it's very effective. If you want someone to be drinking, continually have that visual cue out and in front of them. You can build it into the plan of care. If staff start talking about a dignity issue, as long as it's written and it's in the plan of care, go for it. You might want to put it, you have to watch for glare, but even putting that visual aid in like a table tent or like a picture frame that can always be there so it's not getting spit on or dirty and can easily be sanitized and wiped off. There's a lot you can do with that to support people very effectively. So I'm your girl on that.
Yeah, no, I mean, the idea of using that it makes a tremendous amount of sense. And I think it takes us kind of out of silos like, oh, this is just cog therapy or it's dysphagia therapy, because sometimes dysphagia those things are related. They're not just, everything is not in a silo. But what I wanted to ask about that is, so as a mechanism to get patients who with dementia to remember to do something or to initiate the behavior to do something, that space retrieval training works well. But how do we get to the point where we even know what to do with an individual? Because there are so many barriers to instrumentation. There's so many barriers just in knowledge of identifying specific pathophysiology, so many things. And so sometimes I wonder, like with the hyperfixation on airway protection, do we understand how to work with patients with dementia and somebody who's declining, someone who's not cognitively there? How can we reframe this so that we just have a big picture idea of how we can help these people?
Their assessment needs to include, and Rinki, you can jump in too, but the assessment is going to be a little bit different than the typical assessment. You're going to do your clinical swallowing evaluation. We've already said that. You need to get that instrumental if you can get it, because if you're doing things like a chin tuck and you need them to remember it, you have to also know that it's effective and that it's not putting, sending the bolus the wrong way. And a quick example of that is before I started the dissertation, I was still practicing as a therapist. And so whenever I could, I was implementing this to see if it was effective as some preliminary stuff before I did my dissertation. And I had a man with an awful dementia and a very supportive wife who we did a chin tuck with. He had had a modified barium swallow study. They wanted him doing a chin tuck. So I taught him with space retrieval to do a chin tuck. He turned it into a song. What do you do when you take a drink? And he would sing, I sip, tuck, and swallow. It was so cute. At the same time, I was doing restorative exercises. And at the end, I went with him as his home health therapist to a follow-up swallow study to see what happened. And on every swallow, when he tucked his chin, he aspirated. So we did such a good job restoring his function that the chin tuck now made him aspirate. And I had to unteach the man with dementia to stop singing the song and stop tucking his chin. And it was a nightmare. So when I do CEUs, when I do talks, I actually say, if you're teaching something like that, you probably shouldn't be restoring also, unless you have a plan to undo it later and get that follow-up instrumental. Yeah, but so you need to
don't stick on electrodes, which a lot of clinicians in nursing homes are told to do. That's how they get their minutes. They'll keep 5 people, because group therapy is now a thing, and stick on electrodes for 5 people sitting in a room, and everyone's having NMES treatment or vital stim, whatever the company is, doesn't matter. But they haven't had imaging to know what the underlying physiological impairment is. That's such a disservice to that patient's time and resources.
Yeah. And then the other thing for assessment that you need to be doing is assessing the environment, because of some of these things that Rinki and I have already brought up. If you look into the work of Jennifer Brush, she has done a lot of work on environmental assessment for people with dementia. And I just want to shout out her environmental and communication assessment toolkit. It's the ECAT. It's specifically for dementia care. It comes with light meters and the type of equipment that you need to do a really good assessment. It's a little bit pricey, so it's not really something like I'm not running out and buying it. But if you're in a place with a population that has high dementia numbers, getting your employer to invest in that is probably a really good idea. They buy the exercise equipment for the people, for PTs all the time. So making that case as to why this would be helpful, it helps boost that nutrition and hydration need. So this isn't just something she threw on the market. I was around when I didn't participate in her data collection, but it is standardized, and it's a very, very good product. So yeah, that's something on the market. It's called the ECAT, and that will help and do that environmental assessment, which includes lighting, glare, all kinds of things, noise. You need to be looking at those factors.
Can you talk maybe just for a minute about the influence of environment on these patients?
Oh yeah. Rinki, do you want to, or you want me to?
No, I can jump in if I need to. Go ahead.
Go ahead. It's your turn. Go for it.
Oh, well, no, I think it's just, we talked about earlier that dementia, the dementia is multifaceted. So the way it influences swallow function is not like you would traditionally see. There's just not an underlying motor function issue. There's a sensory issue. Sometimes they don't even recognize the food. It's called agnosia. You could have food sitting in their mouth and they don't know what to do with it because they don't get that sensory input, or they don't recognize food as food anymore. So they don't know they have to chew and swallow. And then on top of that, you have those cognitive and behavioral issues that are going to get exacerbated if the environment isn't setting them up for success. So that could be a very distracting environment, which again, coming back to nursing homes, that's typically what lunchtime looks like. A visually overstimulating environment. They just have too much on their plate, or they have utensils that are not necessarily something they're traditionally used to. So maybe they don't even know what to do with the cup or the plate in front of them. Sometimes they need adaptive utensils where maybe they have physical limitations that don't allow them to eat as successfully, which is then going to take away from that eating experience. So environment is so huge to just manage those behavioral issues. And I've even seen some patients, I'm thinking back, where literally fixing something like how frequently they ate and what time they ate. So doing like a timed snack protocol, and there's some data to support that as well, where they got 6 smaller meals in the day at a time when they were the only person in that room eating or had less distractions, basically fixed the issues they were having at mealtime. So I would say it's as important as the treatment we provide in terms of exercises or anything else we're doing with these patients.
I'll jump in to like piggyback off of that. With those sensory issues, those are happening because of physical changes in the body. So with vision, people with Alzheimer's can get like a yellow coating over their eyes. So the colors that they see change, their depth perception changes, their tolerance for noise changes. Like things about their body are changing in their sensory system. So making those sensory changes, if you think about the food at a nursing home, is typically you've got like an oak floor with an oak table or a white table with a white placemat, if there even is one, and white dishes, and then like chicken and mashed potatoes. There's no color difference. So sometimes it's a matter of getting different colored plates or different colored tablecloths or different colored placemats, trying to make some kind of perceptual difference there so they can see the food, or serving them in colored monkey dishes, like little bowls where there's just one presentation at a time so they're not overwhelmed, can make a big difference. And then with lighting as well, glare is a big issue, but even it's called foot candles, which is how much light you need to see something and be effective. Another story I often share is I was at a nursing home that their dining room was this big dining room that it was broken into 3 areas. And one area near the windows was storage. And then the middle area was like almost their restorative section. And then the main section was all the way to the right across from the windows. And I walked in, a guy's intake had gone down, and I walked in and the lights in the middle section were off. So you had the lights on the right section where everyone was, and then there was a 3/4 wall with light coming in over the wall from the storage section, and that's all they got. And in this case, the table was dark and it was hard to see. And I actually had to put his care on hold because there was no light switch in the middle section. And so I had to work with administration and the maintenance guy to get the lights on in that section. And I made a case and I said, these people are in restorative. I bet you a lot more of them are going to start eating if you get the lights on. And when they did, his eating was fine. So sometimes it's that little of a thing, but with dementia, it's so much more of an issue because of those sensory issues that then that dark table or that dark plate ended up being to the benefit for him because of that perception issue that he had going on. But he ended up not really needing any therapy. We just needed to get the lights on.
Wow. That's very fascinating. I mean, when I'm thinking of environmental modifications, I'm going back in my head to the idea of, with so many of these individuals, that procedural memory is the last thing to go. And so if, you're familiar with a place in the environment, okay, this is time to eat. And that's like a cue for your brain that you get hungry, you start salivating and you start eating. There's so much more to this though. And thank you for elucidating that. Before, I think we've got about 10 minutes. I want to make sure to touch on one idea very briefly. So with the idea of nutrition and why it's important, because there are a lot of things that we do that compromise nutrition. When you puree foods, that it adds water content and it makes it, that there's less taste there. So not only is the texture something they're not familiar with, the taste is less, there's more water content, so they will get likely to get full earlier. That is probably going to have an effect on their nutritional status, at least in many of these patients. But the idea of like when you get older, you can't maintain homeostasis, balance internally and externally as well as you can when you're younger. Your energy reserves go down, and in the process called homeostenosis. And so particularly when you have individuals who are in a skilled nursing facility who are doing physical therapy, who are moving, your body needs energies for your muscles to contract. And when you get sick, your body needs energies. I keep saying energies. Your body needs energy to fight the illness. And so I know I've really been harping on this, but kind of the recalibrating with how important that is. There are a couple strategies that I want to throw out there, but I had much more experience with patients with dementia than I have. So I would love to get more from you about how we can facilitate this. Rinki, you mentioned the idea of like 6 meals a day rather than 3 meals a day. I've heard the idea of just making snacking very prevalent, or on med passes, like when you pass meds, give them a snack too, if they can eat with the medication and that sort of thing. What other types of strategies have you found to work for increasing nutrition? Or
I
maybe
feel like we touched upon this, but it's so individualized for each patient. Like it ranges from, like Jeannette said, minimizing distractions and modifying the environment to set them up for success. A lot of it might involve, like I said, at some point in the dementia process, they are going to likely need assistance, whether that's feeding assistance, one-on-one, like supervision, actual one-on-one assistance the whole time. You have to train the caregivers. That's part of what we do as therapists too, to provide that assistance in the safest way possible. So again, we're making sure that patient is eating as best as they can because they need that support. I think cultural influence is such a big thing as well. Personally, for me, coming from a different culture, I didn't grow up eating bread and sandwiches and burgers. That's just not normal for me. Like for me, rice is part of my everyday meal, which we don't often get at nursing homes, or I grew up drinking tea and not coffee. Like all of us have our own thing that, again, it's a relationship with food that improves that quality of life or that experience at mealtime. And I think we forget that something as therapists because we're so fixated on this is what they're getting today. They have to eat it. I have to make sure they don't choke or aspirate, and that's my job. And it's so much more than that. So sometimes even having conversations with the family to see what that patient's relationship is with food, what finger foods they're more likely to eat, what they enjoy, having the family bring that in if possible, and seeing if that makes a difference might help. Modifying textures, playing around with different tastes might help as well. Those are things that have helped me. Or even something like playing music the patient likes that calms them down during mealtime if they're alone in their room might improve the experience as well. So I think it's just different for each individual and a lot of trial and error to see how we can allow them to dine with dignity as long as possible.
I just want to tongue in cheek be like, you're almost saying like we should collaborate with an individual to like find out what they value and what's important to them and like their history. Yeah, that's amazing. That is amazing.
Something I used to do, I worked at one building where our therapy staff was awesome. It was a county home, so not a huge budget, lots of lower income people, lower socioeconomic status there. And we used to take turns just buying snacks at just like the dollar store or Walmart. And we would have a snack station in the therapy room with ice water and coffee. And I mean, these weren't expensive things. And I know it's hard to do that, but it was really important to us. And the patients, or residents, because a lot of them were long-term, the residents really enjoyed coming to therapy. And sometimes they would just sit around in the therapy room and have a snack and coffee even after they were discharged. But that's another way. I used to get physical therapists to make sure that they were giving the residents water when they were working.
Yeah.
Because that's just another way to boost hydration. And as you said, Tim, your need for that goes up as you're moving around and working. So getting the other therapists to support that too regularly, even if the person wasn't on my caseload, is helpful. Now, getting that to generalize outside of the therapy room where the nursing staff is doing that, that's harder, obviously, because they do have those bedside cups. But at least when they're in your presence or people are in your therapeutic environment, you could be getting your colleagues to support nutrition and hydration as well.
Can I add one more thing, if that's okay? Just because I think, again, we think of our jobs as we have to fix the swallow. And with individuals with dementia, that's just not going to happen. They are going to get worse. It is a progressive disease. And having worked in nursing homes again, where administrators don't want to support instrumentals, you have a rehab director telling you have to see somebody for 42 minutes because that's what they're paying for, when this patient doesn't recognize you the minute you walk out the door, and then you're watching them get worse every day. There's not a lot of appreciation for what you bring to the table, and it's really, really an emotional, I think it drains you emotionally more than working with other patient populations. But I also think the value we can provide, if we like step away from that and really think about the humanity of that patient, really think about the compassion and care we can provide, even in just educating caregivers or trying to change a process or policy at the nursing home, trying to advocate for instrumentals. There's an article I wrote for the ASHA leader about that, and I'll send you that, Tim, if that might be helpful.
Sure.
You will be making a difference for the next 10 therapists that are going to follow. And you may not see that impact right away because that patient with dementia is getting worse. But I truly think we have such an important role to play in the lives of these patients. It's just something that's not talked about or appreciated enough. So we need to do a lot more advocacy and education.
Yeah.
Yeah.
And I think there's a lot of calibration with what we're doing. Like you mentioned the depression, because people are getting worse, that we're not getting a sense of fulfillment as much as like, oh, we did 10 weeks of therapy and look how much their swallow changed, that it might be more focused on quality of life or something else.
Tim, I wanted to bring up one more thing.
Yeah.
In terms of upping that nutrition and hydration. A lot of the other work that Jennifer Brush does is on Montessori techniques.
Yeah.
And so she has a lot of research on that whole thing. But part of that is preparing the environment for elders to participate for themselves. And something that often includes is like a snack and hydration station, kind of like I was just talking about in the therapy room, but preparing it to invite people to participate in that station. So putting a water pitcher where you just flip the tab up and the water comes out, but putting a stack of cups with the water and a bowl of fruit or something with a sign that says, please help yourself to a glass of water, or please enjoy a snack, with those signs in front are very helpful for people with dementia. And there's two things there. One, my very first article that I ever published was reading in dementia. And at the time, it was the only thing published on that topic. I don't know if anything has ever come out after that. But what it showed was people with dementia can read way later into the stages of dementia than you would think. And it is much more effective if there's a personally relevant picture. So on those visuals, if you put a picture of a cup with the invitation to take a drink, it's going to be more effective. On the snack one, if you put a picture of an apple or a banana, it's going to be more effective. So that's thing number one. Thing number two is, as we're talking about these visual aids, because of these sensory changes, people with dementia do not read black writing on white paper as well as they read white writing on Kelly green or royal blue background. So when you're designing the visual aids, changing the color to be more appropriate for the person to read is going to be even more effective. So that might mean I've stenciled things by hand, I've used a Cricut, but now in 2024, you could buy white markers. Buying green or blue construction paper and writing that invitation in white will be very effective. So that's another way that I just thought of to bump up that nutrition and hydration.
Yeah. I mean, I appreciate a lot of very practical examples. There are many other things that I would like to talk about. I mean, I'd like to get into water protocols. I'd like to get into when is it appropriate to use a modified diet? Like, are there circumstances that you can think of that can help somebody? I mean, I think they exist. I just think that we're kind of disproportional with that. We are kind of running out of time. So I just want to at least mention those things as something for people to look more into. I know you have like a 2.5 or 3 hour MedBridge course on water protocols, Jeannette.
Oh my gosh, I've got right now, I've got a 10 course catalog on MedBridge. But yes,
there you go.
One is water protocols. Another one is, if you were interested in the space retrieval, there's 2 on that. The waiver course talks about the legalities of supporting people you might think need a modified diet and don't want it. The pre-oral dysphagia course talks a lot about the environmental stuff. And Jennifer Brush has a Montessori one too.
Very cool.
if anybody first of all, MedBridge and Jeannette's courses are amazing because I've taken them, and that's kind of my first introduction to Jeannette before I even met her was what an amazing instructor she is and how functional her recommendations are. It's not just textbook stuff you need to learn. But if you're looking for a free overview, Dr. Nicole Rogespolia, who's an expert in working with individuals with dementia, and myself, we did a free webinar for the National Foundation of Swallowing Disorders on dysphagia and dementia. I'm sure you can Google it. I believe it was 2 hours, maybe an hour and a half. I don't remember, but it's like an overview, big picture of what we should be doing and talks about pretty much everything we talked about today. And then I think Jeanette's courses would be a much better, deeper dive into like somebody who's working with this population to advance their knowledge a little bit more.
I want to plug that, Rinki. Tim, if you link that up, listen.
I'm writing notes what to link.
You don't need CEUs reported to ASHA to count them. So if you watch Rinki's thing, that's called a PDH, a professional development hour. If you watch that, you just keep track of that yourself. Do you know, Rinki, at the end, is there a certificate for watching it?
You get a certificate. Oh, well, I got a certificate for the live one, but I'm sure if you email the National Foundation of Swallowing, like they'll give you one if you want one.
Yeah, that's how you keep track. So go do that for free. Right there. Boom. Keep track of it. Doesn't need reported to your state or to ASHA. You just hang on to it if you're audited and you're fine. Go get it.
There you go. Well, today was by no measure comprehensive, but I am surprised. We covered a lot of ground. There was a lot of ground covered. So we'll post some additional resources for you to look more into other things like water protocols, more in-depth stuff on environmental assessment and so on. But what I'd like to do, I'm going to try to go back and summarize what I think are some key points, and please add to it if there's anything I missed. One, we know the importance of imaging with many other patients, but it's still incredibly important working with patients with dementia, identifying if there's something anatomical or identifying whether or not there is actual dysphagia, because from what we've learned from Bice et al. In 2023, that so many people are on modified diets or even have feeding tubes when they don't have dysphagia. So we have to know what's going on. Two, the importance of collaborating with patients and families to see what their values are and how we can best facilitate. Sensory testing. So within the cranial nerve oral mech, making sure to do some things with sensation, focusing on nutrition, hydration, quality of life, and pulmonary consequence. So the safety component of that too. Water protocols. I mean, there's so much more. What would you all throw on there that I missed?
You said sensory testing, but I think you can add environmental testing.
Yeah. Cool. Rinki, anything?
I want to add advocacy, and I think we talked about changing our roles. I think this is the population where you have to be able to switch from an active rehab role to a passive advocacy, allied, being an ally for the patient, being their voice towards the end of life and palliative care if needed, because a lot of these patients will end up on hospice or need palliative care. So I think really understanding what our role is then, what our goals look like, what kind of support we can provide and education we can provide is really important. It's just going to look so different at each stage of the disease.
And not being afraid to take the lead and educate parents.
Family.
You tell your mom what to do.
We talked before we started that right now I said I'm raising my mother because she's sick and staying with us. So I feel like the parent. What I meant was educating the family, because we are the experts in the room. No one has more information on swallowing issues, these sensory issues, and dementia than we do. And no one else is going to take that role. So I can assure you, when it comes time to start talking about a feeding tube, no one is presenting the research that Rinki talked about earlier, that they're just thinking, oh, it's going to save my loved one. And so giving that balanced and unbiased opinion, or not opinion, that balanced and unbiased conversation and giving them that information so they have all the information to make decisions is really important. And we need to be the ones to do that.
Could I add one more thing, Tim? Because Jeanette brought up how we are the experts in the room. And the only difference here is I'll say we're not often the experts in the room because we're not trained to be. We're supposed to be, that's the perception. But we have evidence again to show that clinicians are not given training to work with individuals with dementia or the aging population or understand the complexities of this disease. So it's okay if you don't feel like the expert, but then acknowledge that and then recognize that if this is the population you're working with on a daily basis, take the continuing education you need, some of which we've mentioned earlier. There's free articles you can read. You can reach out to authors if it's behind a paywall, and you can try to get access to their research, and then figure out what's the best way you can educate yourself to then empower these families. You can't just walk into it and fake it till you make it. That's just not going to work with this population.
That's so good. Yeah, I love that.
Love it. All right. Thanks, everyone, for tuning in. And if you have any questions after the fact, send me an email, tim@swallowthegap.com. I'm hoping to post a forum where people can go onto the website and actually post some follow-up questions. I haven't gotten to that just yet because there are at least 100,000 other things in the mix, but I'd like to promote interaction and more follow-up because we can't be comprehensive in this, and we're not going to say something that's going to be applicable to every one of your patients. So I hope you're asking these questions in your head. I hope you're thinking about the things that that maybe we didn't mention. So really appreciate it. Appreciate what you all can bring to the table. Thank you, and we will see you next week.
Bye.
That was Dr. Jeannette Benigas and Rinki Varindani Desai discussing a topic that deserves probably more attention than it gets: dysphagia in individuals with dementia. If you haven't already signed up, I'd love to have you join our webinar on April 20th with Dr. Martin Brodsky, Joe Puntil, Dr. Kendrea Grant, and George Barnes. You can get more information at swallowthegap.com/live courses or a shorter URL at gapslp.com/live courses. There are a couple more weeks left of early bird prices, but that will end at the end of March. And we truly appreciate you as listeners of the podcast. Please tell a friend, leave us a review if you benefited from this, and don't hesitate to reach out with episode ideas. We couldn't succeed without our listeners and those who engage with us. So thank you so much, and we hope to see you around.